Center of Excellence Research Grand Rounds. I'm Donato Tullo, the Director of Research at the Center. I'm excited to introduce our presenter today, who is Dr. Sara Jackson, presenting the talk titled Personalized Advanced Care Planning, Meeting Patients Where They Are. Dr. Jackson is an assistant professor of nursing in the University of Utah. Dr. Jackson is also an assistant professor of research in the Division of Health Systems and Science across the lifespan at the University of Utah College of Nursing. She received her MSW from Portland State University and her PhD in nursing from the University of Utah. Dr. Jackson then completed a postdoctoral fellowship through the Utah Clinical and Translational Science Institute STARS TL1 training program, where she focused on assessing and addressing unmet social needs in medical settings. Dr. Jackson now leads a research team involved in multiple extramurally funded projects, including an NIA R01 to develop a measure of financial hardship for LGBTQ plus and non-LGBTQ plus persons living with dementia and their care contributors. Dr. Jackson is also the principal investigator on an Alzheimer's Association funded study, which aims to co-design a culturally appropriate end-of-life planning guide for Hispanic and Latino Spanish-speaking persons living with dementia and their care partners. Prior to her research career, Dr. Jackson worked as a licensed clinical social worker in various medical settings, including at Primary Children's Center for Safe and Healthy Families, the Primary Children's Emergency Department, and Huntsman Cancer Institute. Dr. Jackson's long-term goal is to lead a program of research into the structural determinants of health that disproportionately affect historically marginalized populations in the context of chronic illness. And before we pass it on, I just want to invite folks, if you have questions or comments, to feel free to raise hands or put them in the chat, and I will give a shout to Dr. Jackson to let her know they are there. There will also be a time at the end of our talk for questions and comments. Okay, thanks so much. And go ahead and take it away.
Right, thank you for that introduction. Let me get all situated here. I think the reason it's black here is because I put closed captioning on. Oh yeah, there, it's working. Okay. Can somebody give me a verbal yes that you're only seeing my slides?
Yep,
Yes.
looks good.
Perfect. Okay. Well, since you gave me such a great introduction, I won't spend too much time on that. If you're confused about where you are, because you're supposed to see Dr. Sara Bybee, you're in the right place. My last name is now Jackson. And as mentioned, I'm an assistant professor at the University of Utah College of Nursing. When people ask me about my program of research, I tend to say that I look at structural determinants of health that disproportionately impact underserved or historically marginalized groups in the context of chronic illness, hospice, palliative, and end-of-life care. And I'll get to that in just one second, but my presentation today is really about personalizing advanced care planning. And as many of those social workers in the audience might know, this is really all about meeting patients where they are. So I'm going to be using some examples, not only from my research, but also as with my background as a licensed clinical social worker. So you might be thinking, what do structural determinants have to do with advanced care planning? And my hope is that by the end of this presentation, you'll be able to identify some of the structural factors that might impact advanced care planning and the completion of advanced directives, and maybe even start thinking about ways to overcome some barriers. First, I need to acknowledge the University of Washington Cambia Palliative Research Care Center of Excellence for hosting me today. Thank you very much. I also need to acknowledge the University of Utah Center on Aging, the Emma Eccles Jones Nursing Research Center, the Hospice Foundation of America, the Alzheimer's Association, and the National Institute on Aging. All of these groups have in some way funded or supported my work, and basically, this presentation touches on a lot of different projects, so I'll include them all just to be safe. So I'm aware that given this is a palliative group, you probably all know what advanced care planning is, so I won't spend a huge amount of time on this, but I just wanted to make sure we are really operating from the same definitions. So advanced care planning, or I'm going to refer to it as ACP a lot, is really this process. It's about making plans for future healthcare and or end of life. And it tells healthcare providers who you want to advocate on your behalf if you can't communicate your own decisions. There's also a common misconception that this is really only for people who are older or who have some type of chronic or terminal illness. And it really is for everyone and should be done now before any cognitive decline happens or before there could be any possible accidents that render you unable to share these decisions with medical providers. It can also facilitate discussion. So if you don't know where to start about your end of life wishes, having a chance to engage in advanced care planning can get the discussion going. It ensures that a trusted person will be your medical advocate and ensures that you get the desired medical care that you want and prevents you from not getting the care you don't want. It can also prevent distress of medical proxies or caregivers. Okay, so within the larger umbrella of advanced care planning, we have advanced directives. Now, this is a legal document that allows one to make plans about their future health care. It depends on the state, but usually it can include identifying the medical proxy or what we call medical power of attorney, some choices about life-sustaining treatment and location of care, sometimes organ donation, sometimes research participation. This can be especially important to complete if family members might disagree on future care, or even when the medical proxy might not be the legally authorized representative. So, for example, in the LGBTQ plus community, a chosen family member may be listed as the medical proxy, but if they're not the legal next of kin, it's really important to get that documented and notarized or witnessed, depending on the state, to be legal so that it is in paper and can be uploaded into the electronic health record. So there's no question about that at end of life. Usually the way to get this legal is to have somebody witness the person signing it. This person cannot be related by blood or marriage, and they cannot have access to your medical records, so none of your medical providers can serve as a witness. I've found that in my clinical work, this really does help people get a sense of control over their own care. Having them be able to write their own name and their pronouns can specify what they would like to be referred to in the future. One concern that we've kind of seen is dead naming or using somebody's name that they've used before transitioning. So having ability to also discuss end of life plans for burial or the way to be dressed is also a really important thing for the LGBTQ community. Okay. Again, I'm going to really skim over this because you guys probably all know of this, but I've included the link for the Washington State Advanced Directives here, which you can see on the left. What we know from the literature is that despite the benefits of completing an advanced directive, the majority of folks don't actually complete them. So we have a completion rate between 5 and 15% for the general population. And then for those who belong to a minority group, such as LGBTQ folks or Hispanic and Latino Spanish speakers, this rate really drops even lower. And the thinking behind this is that this could be due to fears of discrimination and stigma. But I'm also going to talk today about some of my findings, which seem to be a little bit more culturally nuanced and surrounding what it is to talk about death or how we talk about that. On the right-hand side of your screen, I've included a link, and I'm going to share these slides so you won't have to write any of this down. But there's a link for this website that has some great resources. It walks you through how to complete an advanced directive. And if you scroll down lower on the page, you'll see this section that has a lead guide. Now, this is a guide that I helped develop with the PI, Dr. Kara Dassel, that is an advanced care planning guide for people living with dementia and their care partners. And this helps them kind of think through what types of decisions you would make now when you can make those decisions for yourself. And then in the future, if you can't make those decisions, what types of choices you would make then. So it's really kind of a helpful way to start thinking about end-of-life care in the context of dementia. So this is the lead studies flyer, and I just wanted to include the QR code here for anyone who's interested in learning some more information. So the lead study, the lead guide has now been translated into an online intervention for people with memory loss or at risk of memory loss, and it's being evaluated in an R01 through the National Institute on Aging. The lead guide has also been translated into Spanish by a community advisory board of Spanish speakers from many different countries. And I'll be talking a little bit about the study that I'm doing, which is to take the Spanish lead guide and adapt that to an intervention for Spanish-speaking families facing dementia. So if you have anyone you think who might be interested in participating in the lead study, here's the QR code again. There's one other resource that I wanted to point out that might be helpful, specifically in the context of Alzheimer's disease and related dementias. So this book here, Living with Grief, Dr. Kara Dassel and I co-wrote a chapter on advanced care planning in the context of dementia. If you click the link, that'll get you right to where to order them. And because our time is limited today, and I really would rather have this be have an opportunity to have a discussion at the end and less didactic. I'm not going to go over everything that's in this chapter, but wanted you to know that there are some really great resources in here, and we cover things like conceptual models, different advanced care planning tools, how you would get financial and legal matters in order, durable financial power of attorney, estate planning and last will and testament, guardianship and conservatorship, protecting against financial exploitation, which is particularly important in the Alzheimer's disease and dementia realm, planning for long-term care, ethical considerations, and hospice and palliative care options. Okay, so now that I got that out of the way and we're all kind of on the same page, I want to talk about why I'm talking to you about advanced care planning with diverse groups today. So things like distrust of the medical system or lacking linguistically or even culturally relevant advanced care planning tools can lead to lower engagement of historically marginalized groups. So in the context of advanced care planning research, not including a group of diverse individuals means that there are these critical gaps in understanding, which then perpetuate health disparities. In a clinical context, research shows us that for those who don't engage in advanced care planning, they may experience more unwanted procedures, treatments, and hospitalizations at the end of life. And then their informal caregiver can experience anxiety related to serving as the medical proxy. They're also more likely to experience complicated grief after the death. So since anxiety and grief are also associated with physical outcomes, this means that both the person completing the advanced care planning, or not completing it, I guess I'm trying to say, and the caregiver or caregivers can then experience worse physical and mental health outcomes, perpetuating health disparities. On the other hand, if you authentically engage in ACP with historically marginalized groups by culturally tailoring the process, their inclusion in clinical research and in the ACP process can really foster health equity by improving their outcomes. So we don't want to do that one. So that's what I'm going to be talking about today. And if you've ever conducted research or worked with a community who's been historically under-researched or overlooked, you've probably heard the phrases difficult to reach or hidden populations. I really hate those terms. I think we need to reframe the way we speak about these groups as saying that a group is difficult to reach or hidden. It really puts the responsibility on the very communities we're trying to help. When in all reality, my feeling is that it's society that's influenced these communities' need to protect themselves. So I'll be using two theoretical frameworks that can help us better understand this. One is called General Unsafety Theory of Stress, or GUTS theory, and the other one is Social Safety Theory. GUTS theory really posits that chronic threat vigilance is this baseline state for humans because we evolved in a dangerous and uncertain environment, so we had to adapt. According to GUTS, automatic threat vigilance is only disengaged by unmistakable safety cues. When I first started learning about these theories, I thought GUTS was like the stupidest acronym ever. But if you think about it, it's kind of perfect because it's a feeling, you get a gut feeling about not feeling safe. And I want to give you a very first world example of this. Have you ever walked into Costco and you see those people standing near the electronics and they're wearing like a collared shirt and name tag, they have a clipboard, they try to make eye contact. What do you do when you see them? Well, I don't know about you guys, but I avoid them. Like, don't look at me. I'm looking at my phone. I'm not paying attention. Like, I don't want to buy something I don't want to buy. That is my default state of threat vigilance, right? So on a level that we're talking about today, I think this applies not only for engaging in advanced care planning, but also for engaging in research. So when we think about social safety theory, this expands the guts theory a little bit. And what it tells us is the most powerful off switch for this chronic threat vigilance is really encountering a warm, affirmative, and protective human being. So to me, this brings two major insights about either engaging in research or engaging in advanced care planning with historically underserved groups. What this tells me is that people are likely to occupy this threat vigilant state, especially that we're talking about research or medical settings, which usually provoke uncertainty or vulnerability. And then you're adding on this layer of talking about death, which is really anxiety provoking for most people, if not the majority. It also tells us that social safety cues can disengage social threats. So why I'm saying this is that this leads us to expect that maybe the most common reasons for declining participation in either clinical research or declining engaging in advanced care planning with a clinician is less about lack of interest and lack of time and more about social threats or expectations of social threats, such as rejection, abandonment, and judgment. And we'll talk a little bit about those later on. I think I saw there might have been a chat. Is there any questions before I keep going forward?
There was someone just appreciating your language around the, oh, I lost the topic. Lauren, if you, I don't know if you're able to unmute.
I think it was the language around the hidden groups that you were
Oh, yes,
mentioning. Difficult to reach
difficult
or
to
hidden
read.
groups.
Yeah, thank you.
Thank you. All right. I'm not going to get into the details from the study that I'm going to talk about, but I've included the link in the DOI here in case anybody's interested. Sorry, my nose is running today. So I participated in this study where we were looking at social threats related to people who'd come into an ER and be asked to fill out a social screening form about any unmet needs. And the social threats that we noticed were many. And because of that, we decided to kind of develop a way to address these threats to hopefully be able to engage people more in getting their needs met through social service organizations that we were trying to connect them with. So in terms of aggression, this can look like calls to child protective services, immigration, and asking questions in an imposing manner. And findings from this study suggest that to head off concerns regarding aggression, we need to really assure folks that no authorities will be contacted and ask, is this a good time to talk to you about ACP, or is this a good time to ask you a few questions about participating in research? I do recognize, though, that things are changing very quickly, and you'll have to definitely be more aware of the laws in your state. And I'm just issuing like a little warning. I can't blanketly say that no authorities will be contacted because I don't know how things will look in the future. So just be careful with that one and don't state that unless you're absolutely sure. Breach of confidentiality. A lot of people were scared about like who's going to get this information? What are you going to share? Is it going to be in my health record? So to address this concern, depending on if you're conducting research or you're engaging in advanced care planning, you can try to assure someone that their information is going to remain confidential and won't be shared with outside agencies. You could even suggest, if you don't feel comfortable having your advanced care plan, your advanced directive uploaded into your electronic health record, we could complete this and you could just take it home if that's really a concern. When we heard about devaluation and condescension, people were really talking about being spoken down to. So to counteract this, we really need to speak to the person at the same level, assure them, and treat them as if their time is valuable. Discrimination fear is really focused primarily on treating individuals unfairly or inhumanely, mostly based on their race or ethnicity. One way to not counteract this, but kind of approach this is to state why you're doing what you're doing. So a lot of times as clinicians or as researchers, I think we just assume that everybody knows like, oh, we're conducting this research because it's going to help people, or we're going to ask you questions about your end of life wishes because ultimately it's to serve you, but not everybody knows that. So we need to be very clear This is why I'm asking you these questions, or I'd like to ask you these questions. Is now an appropriate time? And really give them information before they automatically shut you down, I guess is what I'm trying to say. Concerns about exclusion, we refer to concerns about like involvement of individuals who are undocumented. Again, to address these concerns or anticipate them, we can assure participants that no one is excluded from research or from engaging in ACP based on immigration status. Again, if this is true, I don't know what's going to happen in the future. Insincerity concerns were about participants worrying that the research team member or the clinician was asking questions just to check a box or fill out some form, but they could tell they really didn't care about the person. We really need to focus on building rapport. Again, as social workers, like you know that is the main building block of any therapeutic relationship. People generally respond better when they feel the person asking them questions genuinely cares. And rejection. So this referred to when participants felt they put themselves out there and they were rejected by a person or system with which they were engaging. To address this, don't make any promises you can't keep. Follow up if you say you're going to follow up. If they ask for help regarding something that you can't help them with, offer to connect them with someone who can help them or follow up with information if desired. So in addition to understanding more about how to foster social safety, I'm going to really not go over this, but just wanted to mention cultural humility as a framework and tool that was designed to improve healthcare for culturally diverse populations. So some of the key attributes are listed here. Again, I'm not going to go over them right now, but I really wanted to point out is that to me, there's a big difference between cultural humility and cultural competence. Cultural competence is this idea that I'm the expert. Cultural humility is this idea that you're the expert. You're the only one who really knows expertly about your condition because you're living it. So cultural humility is more about this ongoing process of learning, of incorporating new knowledge, of being open to feedback. And it has a little bit more, to me, flexibility than this idea of like, once I learn this, then I'm forever culturally competent. Now, I'd like to move on to some specific information about cultivating trust with Hispanic and Latino populations. We'll get to advanced care planning with this population in just a second. So I'm currently the principal investigator on an Alzheimer's Association study. This project is called Fostering Equitable Dementia Care in Hispanic and Latino Communities. And as I mentioned, we're taking the Spanish language translation of the lead guide and now adapting it into a culturally relevant intervention. We're partnering with a community advisory board as well as community-based organizations. So one thing I've learned from doing this research and from working with Hispanic and Latino populations at Huntsman Cancer Hospital when I was engaging in advanced care planning is to make an effort to learn the language and the culture. I'm not saying that as a researcher, you can just jump in and be the person conducting the interview if you don't have fluency, but learning a little bit of language really does go a long way. I found that if I try to speak in Spanish with folks, even as just a conversational piece, unlike in France, where I feel like they're like, why don't you just speak English? People are always really open and impressed that I want to speak Spanish with them. One other thing to remember, though, about learning the language is that each country uses a different dialect. So it's going to vary depending on which country your participant or your client comes from, what kind of dialect and accent they have, and what words they use. Hiring bilingual and bicultural staff is another big recommendation. The rest of these recommendations are more for engaging in research with this group, but I think can be applied to advanced care planning. And those include attending community events, establishing relationships with gatekeepers or community organizations. As I mentioned, we've been working with a number of community-based organizations. Ensuring your flyers are representative of the population and easy to read. This is a tough one. So this is an example of a flyer that we've been using on our Alzheimer's Association funded project. And my study coordinator, Nicole, who I believe I just heard on this call, did a wonderful job in incorporating some changes based on feedback we received. So I don't know how many iterations of this flyer we've done, but every time we do a new iteration, which is directly from feedback of Spanish, native Spanish speakers themselves, we keep hearing like, oh, this doesn't make sense, or that doesn't make sense, or this word is really offensive, or like, we don't even know what you're talking about here, or don't mention death. So it's just been changing over and over and over, but we've learned a lot. And I think that's just to show that depending on the community you're trying to engage with, you might have to change the words you use to start talking about um, what type of medical care you might want instead of saying, let's talk about planning for the end of life, because that is a little bit jarring to some people. Tailoring dissemination, again, just for research, but for our housing instability study, which was in Spanish, we budgeted to include this community dissemination event. We shared our results with participants. We made sure to include transportation to and from the event. If needed, we offered childcare and dinner for each family. And the reason we did this was I'm very aware of this helicopter researcher label as a gringa, and I really did not want to be that person. So this event allowed us to share our results and to also gather feedback on what our participants thought would maybe be the next steps in our research. Once we have some final results, we also plan to discuss them on an independent Spanish radio station to more widely share them with the community. And part of this reason is because, as you all probably know, paywalls are really frustrating. And if we can't access articles, do you think our participants can access them? They're also full of lovely jargon that nobody can understand. So it's really important to think about how can I get this information to the people who could use it the most in a way that they can access it and understand it. Some additional considerations that I'm going to just leave these up here and not run through them, but thought they were important to include. So acculturation and English proficiency might change how much somebody understands about advanced care planning and completing an advanced directive and why that actual documentation might be important. A lot of times, Hispanic and Latino families live in multi-generational homes. There's this concept of familismo. So they might want to list multiple people as their medical power of attorney, or even have everybody in their family present to even talk about advanced care planning. Then we have respect for doctors. Some research shows that Hispanic and Latino folks are reluctant to question the recommendations of a doctor or to even ask questions. So we need to make sure that folks feel comfortable enough to ask questions about ACP. Caregiver versus clinician views. Some caregivers might see their role as like the hopeful party, like they're the one who's going to have faith that their family member is going to have some miraculous improvement. And they view the clinician as being pessimistic. There's this greater desire to shield a patient from negativity, which can mean you might need to speak to the care partner or caregiver separately. One thing we've noticed a lot is unawareness of available service and resources, depending on, again, where this person's born, how long they've been in this state or this community. There might be some resources that could really help them that they just aren't aware of. And then I briefly mentioned this, but talking about death is often taboo. There is this kind of superstition that if you talk about the end of life or talk about death, you're kind of inviting it in the room. So depending on how you're approaching discussing ACP or engaging in research, you might want to talk around it rather than coming in and saying, like, we're going to talk about your death. I think I missed. So before moving on, I just wanted to point out my postdoctoral fellow in this beautiful picture here, Moroni Fernandez Cajavilca, and he's been working with us on a number of these projects. So our community advisory board came up with some really interesting priorities for interventions about advanced care planning. What they told us was they wanted to be able to have multiple care partners involved in this across borders. So people saying that, you know, my sister, my so-and-so lives in Mexico or Guatemala, and they need to be able to participate in this conversation at the same time that I am. A lot of folks mentioned having a trustworthy professional initiate the conversation. They also wanted the intervention or the guide itself, the advanced directive, to be viewable on a phone. A lot of our participants mentioned that for Hispanic or Latino folks, they often don't sign onto a computer every day. So having it viewable on a phone is really helpful. Including links to resources. So people mention that sometimes when they're going through an advanced directive, things come up that they haven't ever even heard of, and they want to be able to have information on that, have a place to go to learn more about that thing. And then clarifying if it's a legal document. We need to inform folks of the differences between an advanced directive, a planning guide like the lead guide, and even a POLST or a MOLST. I'm not sure which one Washington State uses, but in Utah we used POLST. And then I'm gonna just drop this here. Again, I'll share these slides with you so you'll have this information, but we just heard of this telenovela that was developed in collaboration with the Alzheimer's Association, and it's really about Hispanic and Latino persons living with dementia and kind of how to talk to them about dementia and advanced care planning. So in case that's a population that you work with often or you're just interested, you can click on this. It's actually more like a feature-length film. It's about an hour and 15 minutes. I'm going to shift now to the other kind of specialty population that I work with, and that's LGBTQ folks. So first thing I want to acknowledge is that there's a lot of diversity within this group. For example, gay men likely have very different experiences than lesbian women, who also probably have very different experiences than transgender individuals. For today, I'm going to just kind of talk about the group as a whole, but please know that there's such variation and nuance between each of the letters of the LGBTQ acronym. So some of the things that we've found to be helpful, I've included here: learning and practicing inclusive language, introducing yourself with your name and pronouns. I saw some of you already had your pronouns in your Zoom name, which is great. I've already mentioned building rapport, correcting others when they make mistakes. It's hard to do, but it also it shows that you're thinking and you are working on yourself and can build trust. Challenging stereotypes, creative, inclusive, welcoming environments, and if you're in a research setting, continuing to collect sexual orientation and gender identity information as possible. So I might include the LGBTQIA Resource Center glossary here. There are a ton of terms, and there are always new ones, and I find this to be a really helpful resource. In terms of asking non-judgmental questions, things you could ask are, what pronouns do you use? Or who is it important to include in this conversation? Those things are a lot more welcoming than asking something like, is your husband or is your wife going to be your medical power of attorney? We really don't want to assume things. If you have more questions about how to engage older adults who might identify as sexually or gender diverse, the Sage Care website also has this great inclusive intake asking older adults SOGI questions. I do also, let's see, I missed something in my notes. I wanted to say that when I write challenge stereotypes, this doesn't have to be something huge. So for example, if someone is talking and they say he or she, and they start to move on, one tiny thing you can do is even just say, or they. And like things like that, once they add up, I think they really do create momentum around health equity for this group. So just like with the slide I had about working with Hispanic and Latino populations, this stuff might be more appropriate for research, but I'm gonna pop it in here anyway. So engaging in advocacy can really help you gain traction and trust with this community. Attending events and volunteering, including LGBTQ people on your community advisory board if you're conducting research. Hiring LGBTQ plus staff. Training those conducting research or advanced care planning with this population. Practicing what you preach. Completing trainings, I think I mentioned that. Okay, so here's another link for some on-demand courses that could be helpful. And then at the very bottom, this is a brand new resource that I'm including called Transforming Choices. And this is a website that has some healthcare information and resources to support transgender and gender expansive adults and older adults in making informed and empowered healthcare decisions. This website was sent to me by a colleague of which I've kind of co-authored some things with, and it's brand new again. It's got some great information. It has testimonials, which is really nice. It has links to resources. So feel free to peruse it as you would like. It also has a link to specific advanced care planning guides for trans and gender diverse individuals. And tailoring recruitment and dissemination for this population as well. So we want to make sure that when we are developing materials, that people see themselves reflected in those materials. Okay. Now, specifically in terms of advanced care planning, if you're in clinical care, feel free to check out the publication Social Work Practice for Adults Facing Serious Illness, a handbook for social workers. So this was a NASW Press book that was recently published. My colleague Austin Oswald and I co-authored a chapter on serious illness with sexual and gender diverse populations. And it contains a lot of great background information and other suggestions for social work practice that we won't be able to get to today. So as I mentioned earlier, health and mental health providers often receive little, if any, training in engaging with patients and families about end of life, or even completing advanced directives. There's also a dearth of training provided on working with LGBTQ persons. But what we find is research shows that when providers do receive training on how to provide LGBTQ plus competent care, their attitudes towards LGBTQ persons improves, as do patient outcomes. So just for fun and a side project to address these training gaps, I purchased the licensing rights to the Hospice Foundation of America's Advanced Directive mini plays. These are there's 3 of them. I used 2 of them. They're 10-minute plays, 2 characters each, and they're really designed to engage audience members in active and experiential learning about completing advanced directives with diverse patients and families. So what we did was, over about a year, we conducted 5 ACP education events. This picture on the right is from one of our events and shows our actors performing the mini play called Room 402. So our actors performed the play Lily and Room 402, and then we would have brief discussions and the audience could ask questions. Then we had folks complete a red cap survey with Likert scale questions and then open-ended questions about their experiences. I'm going to click through these very quickly. One of my favorite quotes is this middle one. I love the practical demonstration of the challenges and importance of having an advanced directive, family dynamics, professional conflicts, which are all real-world issues. The learning stuck better from watching these plays. The slide contents and delivery were fabulous too. The reason I'm including this is that I feel like oftentimes as clinicians, as researchers, as educators, we get stuck in this idea that learning only comes from didactic experiences. And I found that this way of teaching folks about advanced care planning to be super effective because they see people engaging in the process, not only patient and medical proxy in one play, but in the other play, it's 2 nurses who are having kind of a conflict in how to approach advanced care planning. So seeing those different dynamics, I think, is really helpful for professionals. What we found, as you can see here, is we had about 129 participants watch these 5 different continuing education events. About 43% were social workers, and then the next biggest majority were psychologists. 90% of attendees felt the mini plays were an engaging way to learn about advanced directives. And then 81% said completely or very true to the fact that the mini plays improved their understanding of advanced care planning. So just trying to put this out there that this is a potential opportunity for an alternative way of engaging in training about advanced care planning. There's lots of other things out there. This is just something that I stumbled upon and happened to speak to me because the play Lily was originally written about Lily, who is talking to her ex-husband, and it was rewritten to be Lily talking to her ex-wife. So the incorporation of this nuance really helped bring up some things that the audience had never really thought about and provided some rich opportunity for discussion. Okay, I think this is my last slide, so you guys are hanging in there with me. At first, I had a picture of an elephant on this because I feel like there's an elephant in the room pretty much whenever I present because of the current policy landscape. So what I want to say here is that I think we can anticipate a heightened sense of threat vigilance from minoritized and marginalized populations, particularly folks who don't have legal documentation and the LGBTQ community. So understanding how to continue to build trust in an authentic manner really is critical. We might have to revisit some of those strategies that I put up earlier to address social threat expectations. All social threats, but especially breaches of confidentiality, concerns about aggression, and even concerns about exclusion might be even greater in the years to come. Regarding breaches of confidentiality, we might consider only collecting demographic information that's absolutely necessary to help your patient engage in ACP, or if you're conducting research, maybe only the necessary information to compensate your participants. For some of our studies, we put data collection on pause so we could make sure that we were safeguarding participants' data and not collecting their addresses anymore, or not collecting certain pieces of information just in case these databases and software were accessible by untrustworthy folks. Some may not prefer to upload their advanced directive. I think I mentioned that. Some things to keep an eye out for the future. Laws surrounding same-sex marriage. This might impact who's automatically considered the medical power of attorney. So typically the order it goes is your spouse, then your adult children, or your parents if they're living. So we need to kind of keep an eye on this for the future to see who might be considered the legal power of attorney, and that might determine how important people feel it is to complete an advance directive. I feel like we also need to keep an eye on policy regarding gender markers on identification, as this could impact advanced care planning and the completion of advance directives. Medicare funding. This might also change who feels it is necessary to complete an advance directive. And one thing that I've been kind of thinking about is, in a lot of the research I conduct, whether it's cancer related or dementia related, people have talked about not wanting to bankrupt their family to afford care. People, especially who have chronic illnesses or feel like they have just fought as much as they want to fight, have spoken up and said, you know what, I would rather my family not spend all their money on a treatment for me that we know is not going to work. So I'm just putting that out there. There's a lot of things that are kind of up in the air right now, and I wish I knew how the chips would fall, but I don't. So these are just a few considerations that we might need to think about for the future. I have listed my references, and I want to thank you very much. Feel free to email me with any questions. And then if there's no discussion questions, I have provided a few to kick us off. So I'd be happy to take your questions or to jump in with some of these. Thank you very much.
Great. Thank you so much, Dr. Jackson. And folks, again, so you're welcome to go ahead and unmute or raise your hand or use chat or whichever way is most comfortable for you to engage. And I'm about to put a link for an evaluation form too. If you would take a couple of minutes to fill that out, I'd appreciate it.
Help me pronounce your name.
Are you talking about me? Seiko Izumi?
Izumi?
Yeah. Thank you very much for the great presentation. It is really the interest of mine. So I really appreciate the depth and breadth of your study and your recommendations. I am curious about those minoritized group, and always struggle with that. Am I imposing the stereotyping them by grouping them like the Latino group or the LGBTQ groups? And because I believe that everybody living in the intersection of those multiple characteristics as a person. So how do you address that when you are talking with a person? My go-to attitude is to focusing on who this person is, regardless which group they belongs to. But do you have any thought about how to dealing with the intersectionality of those multiple characteristics?
Yeah, thank you. That's a really interesting question. To me, the information that I shared today is really about generalities and information to kind of have in your back pocket. Clinically speaking, when I was doing advanced care planning with folks, I'm not going to come into a room and be like, so I see that you're Hispanic and Latino, so you're probably not going to want to talk to me about death, right? It is a very personalized discussion. So I think you're absolutely right. Approaching it as if you don't know anything about that person because you probably don't. At least for me on the inpatient unit, I really had never met these people. Depending on your setting, you might have a longer term relationship with folks. But yes, starting out in an empathic way and stating, why you're asking these questions, I think can go a long way. But you're absolutely right. We don't want to make any assumptions. I think for me, having this information is just helpful to kind of wrap my head around, okay, everybody's different. And these are some things that if I can practice over and over, for example, by saying, who would you like included in this conversation rather than do you have a spouse we should call? There are little things like that that I can incorporate over and over that just become second nature that really help me be more inclusive regardless of the group that I'm working with.
Wonderful. Thank you.
Thanks for your question. One of the questions I had was, does anyone have a story? And I could kick it off. I'll have to think of one. But does anyone have a story about something that they learned the hard way? Like, oh, this is what I learned about doing advanced care planning with this group, and like, you should not do this. So one of the things I think I mentioned was in our flyers for our advanced care planning intervention with Hispanic and Latino Spanish speakers, having the words like end of life and death on there was like a big, I'm not going to do that again. Instead, framing it as let's talk about your medical choices for the future. That was a nicer and more appropriate way, I think, for us to go about it. But does anyone else have any examples of specific things that they learned the hard way about engaging in advanced care planning with diverse populations?
Hi, this is Anne. I'll share.
Thanks, Anne.
I don't have one specific instance, but for some folks, approaching it as, asking permission, gotcha, that this is something you can do that can be helpful to yourself, right? And to your doctors in knowing what your preferences are for the future. But several people said, that's not my main concern. My main concern is my family. So sort of reframing the conversation for a lot of folks that this could be helpful to your family to understand things, right? Understand what's on your mind. To just for me to be more aware of kind of the family aspect and why people may be engaging in this at all. And I think being sensitive to the fact that they may have been asked many, many times. And so if I know that, even acknowledging that, you may feel somewhat badgered or that you've talked about this too much, but is there anything you do want to talk about the future, right? Because some people feel a little overwhelmed. So, yeah.
Yeah, thank you, Anne. That's a great example of meeting patients where they're at, right? They just might say, I'm not interested in this for me, but I'm worried about my family. And you met them where they were and said, okay, let's talk about your family and how we can make sure that they're taken care of. That's
Mhm.
great.
I would add to that, sometimes people say, yeah, I know my family's more interested in me doing this because they really want to understand, but I am just too overwhelmed by thinking about the future, right? Or thinking about my approaching death. Um, and so just trying to pivot the conversation. What do you want them to know? What are some overarching principles that can help them, even if you don't do this thing, right? So,
Good point. Kara, did you have your hand up?
Yes, I first of all, I'm not a clinician, so I don't work with patients, but in my research with dementia advanced care planning, there's obviously a response bias to our intervention. So those who are ready to do advanced care planning tend to reach out and want to be enrolled in the study. But speaking with broader audiences and non-participants, I think thing I did wrong was making assumptions that if someone has an early diagnosis of dementia, that they want to engage in advanced care planning and take that opportunity where there are a lot of people who are very reticent or even in denial or don't want to think about the future because it's too overwhelming. So I guess my tidbit of advice would be kind of feel out someone with cognitive impairment to assess their readiness to discuss future preferences and just be sensitive to that.
Thank you. Yeah, Barb.
Hi, I'm Barb Hansen. I'm an RN and I work with the Washington State Hospice and Palliative Care Organization. And when I have done talks to community groups or like at an assisted living facility, I have found that some people, well, most people don't know the surrogate decision maker laws wherever they live. I'm sure you found that too, but if you show people a list, well, here, if you don't, do an advance directive or complete a pulse form, here's the list of the surrogate decision makers, who may be called upon to make decisions for you. And some people, this one guy said he had never gotten around to getting a divorce from his wife, but he sure didn't want her making the decisions for him. So it's a little bit of like reverse psychology to get people to complete some forms if they're horrified by the list of who might be making those decisions for them. I thought that was an interesting learning experience for me.
I don't think that's actually that uncommon, so I'm glad you brought that up. We've had that. I've seen that not only in presentations that I've given, but also in some of our research with folks who just they're not married to their current partner or they never got divorced, and things get messy when you're talking about not only medical decisions, but when you're also financially planning for the end of life.
Well, in some states, and I can't remember how it is in Washington, so remind me if somebody else knows, it has to be like a majority of your adult children. Well, what if your adult children don't get along and you think, oh, they will never agree on anything, or you only have two, so it has to be unanimous. So there are just some problematic things that can happen when it falls to surrogate decision makers. So if that's a motivation, great.
That's a good point. Yeah, Izumi?
Yeah, I like to share one example that which you mentioned as well. So it was for the research purpose. I was interviewing the Asian person about advanced care planning, and I go through the typical advanced care planning conversation with him, and so I asked, what is the kind of the medical care you'd like to receive, and his response was like, whatever the doctor tell me. And I have, as a part of the research, I have to push very hard to, so, is this what you really want to have? What is this? You are just saying that as a respect for your doctor, because among the Asian culture, respect for the doctor is pretty strong, and it's, regardless what I want, but what I do, whatever the doctor tell me to do. And eventually I get the response from him saying that, well, I'm old enough, I really do not want to go through those, the hustle and bustles. But that was a kind of lesson learned that, sometimes the people say that, that even though you ask directly, they may not give you, but they may give you the more socially acceptable responses. What their response may be skewed by the kind of the cultural respect for the authority or something. So that was the interesting, give me a lot of things to think about.
Yeah, thank you for sharing that. Michael.
First, thank you for your presentation and all the resources. I looked up a number of things. I'm very excited about the plays. I'm very excited to learn more about those. Um, I was thinking in a lot of the work that I do, which is a pretty diverse group of people, especially the racial and ethnic disproportionality and people experiencing homelessness. and complications like, comorbid conditions, end of life care. Um, and I think about it like advanced care planning as like so much of that conversation can be framed about limits to medical care and about like, ideally protecting you from care that you don't want, you may not want. But for people who feel like healthcare systems have often denied them care or worry that their life does not have the same value to healthcare professionals or in healthcare systems, this idea of like things won't be provided to me and things will be withheld from me is just sort of like a kind of a concurrent worry. So I think I'm really thoughtful about how to use language in these conversations that really guards against this perception that the bias in advanced care planning is towards limiting care. That it also really includes, especially, I think we as healthcare clinicians can really have a bias against longevity focused like care. And some of our folks, especially, when there's maybe a religious or spiritual component behind the idea of longevity that doesn't sort of like jive with the rationality of like medical models of care. So just understanding where those intersections like come together, both religious and spiritual longevity, and also the fear of like withheld resources in healthcare settings.
Thank you. I had never thought of that, so I appreciate that comment.
It was a great discussion, but unfortunately we're at time. I'm gonna go ahead and put the evaluation form one more time in the chat, but I just want to thank you all for joining us today. Thank you, Dr. Jackson, for sharing your interesting work. It was an excellent presentation. We appreciate it. Thanks, everyone.
Yeah, thank you all for coming. I appreciate having an audience.